I think most of you know that I have sort of devoted my life since 1995 to circumcision injury litigation and also to preventing circumcisions and some other issues, forced retraction cases and the like. And I thought I'd go over what are the common circumcision injuries that I've seen and their causes. In an adult, it's usually removal of most of the shaft skin, which results in, this is for an adult circumcision, or perhaps a revision circumcision or recircumcision of a previously circumcised adult. A lot of times the skin will push forward and the doctor will think it's foreskin. It's not. When he takes it off, the same horrible result happens that would happen if he botched an original circumcision. It results in penile scrotal webbing, hair on the shaft, a buried penis, loss of useful length, pulling and tugging on erection, and difficulty in intercourse with pain for the partner. In an infant, you have similar things, including excessive shaft skin removal. And the bad news is, I've told this to a lot of people, and sometimes I get shocked looks and say, oh, that's me. If you have an erection and your scrotum is pulled forward significantly on the shaft and there's hair on the shaft, any significant amount of pubic hair on the shaft, fact is you had a botched circumcision as a child. And it's because there is no cut here line, and the doctors frankly don't understand the anatomy and how the penile skin system works, so that even major textbooks on how to perform a circumcision, I think, are absolutely flat wrong. That's the most common thing that I see is excessive shaft skin removal. You also have glandular ablation, which can happen with the Mogan clamp or the Plastibell. You can have a permanent groove in the penis, which can happen with a Plastibell. For those of you who don't know, there are three major ways to circumcise an infant: the Gomco clamp, the Mogan clamp, and the Plastibell clamp. And for those of you who don't know, we'll go through each type here. Strangulation of the glands with Plastibell. You can tear open the urethra in all types, and you can also have uneven skin removal. And I'll add a recent case that I'm working on right now where a child was bleeding. The urologist told an obstetrician, wrap it up with Coban. The Coban is an elastic dressing. You have to be very careful with it. And the nurses didn't monitor it. We're still litigating with the hospital and the nurses. And by the time it was taken off, about 12, 15 hours later, the gland started to necrose, and it necrosed off over the next 10 days to 2 weeks. Horrible injury. So, what are the causes? Well, it's real simple: ignorance of penile anatomy and functioning of the skin system, and negligent technique. And the excuses are, I did what I did every time. It's a known risk. It don't matter none, which is what my den mother in South Carolina used to say when we break something. There's no functional damage. It's only cosmetic. The repair looks excellent. It's only a little snip. We whack them all. These are all quotes that we've heard. He'll never remember, and men love it that way. We've actually had people say that with a significant penile scrotal web, that men love it. Okay. So let's talk about the penile anatomy. First of all, you have the exterior penile anatomy, which includes the scrotum, of course, which hold the testicles, the shaft of the penis and shaft skin. You then have the foreskin, the glands, the end of the penis, and the frenulum, which connects the lower part of the foreskin to the glans penis. On the interior of the skin covering, you have the dartos fascia or muscle. It's also called the dartos muscle, which has a very particular function. You have mobility of the shaft skin and the dartos and the foreskin, which is really key here to prevent injuries. And you also have, of course, the connecting Seneca or balano-propucial lamina or adhesions in the infant, when the infant's born, the foreskin shares a common epithelium with the glans penis. So here we have the penis itself. You have the glands, of course, the corona here. You then have the smooth mucosa on the inside of the foreskin, the ridge mucosa or Taylor's ridge band. On the underside, you have the frenulum. This is being the meatus. The prepuce, once the connections between the foreskin and the glands have dissolved, can be everted. And it can be everted because of the dartos fascia, because the dartos fascia ends right here. And when you pull it back, as it everts, you get the inner mucosa, which is then displayed with the ridge band being displayed along the shaft. Now, this is from the Armed Forces Institute of Pathology, once again, the meatus. The frenulum down here, this is an adult penis with the foreskin retracted. That's the ventral side. This is the dorsal side. Interestingly enough, one thing that I won't go into much, but it happens at every circumcision. You see here the superficial dorsal vein. It actually arises someplace on either side of it's actually in the deep tissues here. It comes out underneath the inner mucosa of the foreskin, goes around in two branches up, and eventually on top joins together and then runs back this way, so that every circumcision disrupts this blood flow back into the body and may be the cause of meatostenosis in a large number of circumcised boys. I've actually had an adult who was circumcised as an adult. It was a botch, but he developed meatostenosis, which he'd not had before, which tends to prove that's what's the cause of meatostenosis, not diaper rash, which is what's commonly thought to cause it. And then, perhaps most importantly for understanding the anatomy, is this cutaway where you see you have skin, which is epidermis and dermis, two layers. You then have the dartos fascia, which actually starts behind the scrotum. It is under the skin of the scrotum, joins what's called scarpus fascia that comes off the abdomen and then goes straight down to the end of the foreskin. And then underlying that, you have the lamina propria supporting layer and the inner mucosa. This is Chris Cold's slide from his article that shows epidermis, dermis, okay, and then the dartos fascia, which is actually the largest part of the foreskin, lamina propria, and inner mucosa. You can differentiate the foreskin pathologically because the shaft skin has epidermis and dermis and dartos fascia, but does not have lamina propria and inner mucosa. Now, what's the significance of the dartos? It surrounds the scrotum, continues down the shaft to the end of the foreskin, and allows foreskin retraction. All right, and here is that shows what happens as you avert. You can see how the inner mucosa is displayed. The dartos allows return of the foreskin so that the inner mucosa rests on the glands and the outer skin protects the glands, which is shown here. And these are John Erickson's pictures. This is essentially the foreskin in a semi-tumescent penis. The ridge band is sort of marked here, where the inner and outer foreskin meet, and then the corona glandis is here, and you can see as you pull back how the inner mucosa is exposed, and in some men you can pull all the way back. And you will also see that you've got to be very careful, and I'll show this in other pictures that are even more dramatic, how much tissue you take off, or you're going to take off too much shaft skin. Once again, on the shaft of the penis you have skin, which is S, two layers, and this red layer is the dartos fascia, and underneath is a fibroadipose layer that's here in yellow. It's whether or not there are tight connections between these layers and the underlying buccal fascia that determine how the penis works, and you have to know that because in many men everything shrivels up, and it doesn't really matter if you're thin or if you're heavy. Okay, it's a matter of are the tight connections or loose connections. A lot of penises you'll see, they're tight connections and the penis sticks out. They're the type that if you get an erection, you will probably pull the foreskin back automatically without touching it. In others, where you have loose connections, that's not going to happen. And this is another cross section, once again showing the skin, the dartos fascia, and the underlying tissues. All right, here is the significance of loose connections between the dartos and buccal fascia that allow the skin to move freely. Oh, sorry. Back here. All right, this is a penis at rest. It looks like you have a larger acropostion, but this is actually the corona marked here, where if you pull all the skin back, you can see it goes all the way back here. And as you'll see in a minute, if you cut here, if you make your exterior cut here, you're actually cutting off all the shaft skin. That happens all the time, and it is the failure of physicians to appreciate this that causes almost all the accidents that I see, except the glandular ablations. Simple. This isn't rocket science. And here are other examples of similar penises. Okay, this is the ancients, if you look at ancient statues, they understood this real well. Look at the Alexander sarcophagus. It was 2 weeks ago in the New York, no, about 2 weeks ago in the New York Times. They showed a colorized version of it. You can see very clearly in one of the figures, penises that look like this. All right, so the ancients clearly understood this. American doctors don't seem to understand it. This happens in babies too. You've got to push back and expose everything. If you just cut off everything, you're going to cut off the whole shaft skin, which I see kind of, and this is, once again, a series of pictures that shows how mobile the penile skin system can be on one individual. Why is it important? If you don't understand this, you will mistake shaft skin for foreskin. If you don't know where the landmarks are, you don't know how much tissue to leave, and failure to leave sufficient tissue for an erection results in lifelong pain and difficulty for the man and his partner. And this is the most common accident, shaft denudation in the adult male. The sleeve resection method is pretty simple, and this actually shows it wrong, but it's cutting on the outside first, and pulling back, cutting on the inside, cutting out in between, and sewing everything up. There are ways to prevent denudation I'm going to show you in a minute. All right, like I said, if you cut here on this guy first, if you make your exterior cut here first, then an interior cut on the interior right behind the ridge, you will have taken off all of the shaft skin and pulled the scrotum forward and pubic skin forward and sewn the guy up, and he's damaged for life. And that just shows it again, but this shows it a little bit better, where you are marking on the outside, you then mark on the inside, you then cut out on the outside, cut on the inside, cut out in between, and sew up. And if you've taken off too much skin, which you see here, right there, if you're joining here to here, you're going to end up with a penile scrotal web. Okay, and this is an example of what you end up with when it's done wrong. You can see it underneath. This is before it's been repaired. This is a diagram by Gary Alter, who is both a plastic surgeon and urologist, probably one of the best reconstructive surgeons in the country. He's in Beverly Hills. I've sent a number of people to him for repairs. All right, so the result, of course, is, as I think you can appreciate here, is you've denuded the shaft, and you really don't understand you're doing this because everything's sort of scrunched up. You think you're doing a wonderful job. You sew the two parts together. That's what you get. And then you say, oh, my God, he had a buried penis because he's fat. I've heard this all the time in adult cases. And the result is this, okay? This is what you may look like. Oh, that's okay. No, it's not, because once the hair grows out and everything, you've got a horrible result. This is the same guy before the circumcision, and this is the result afterwards. Terrible. And erect, that's what you're going to get. And this is just a comparison of a correctly circumcised penis that does not have any significant pubic hair on the shaft. Although it's taut, you still aren't pulling the scrotum out. And this is, of course, the botched circumcision. All right, now there's a conservative repair without degloving or a skin graft. It's where you take the wedge out. I'll go back one. You would take out this wedge here, and then you'll close it there and cut that, and you'll actually reduce the scrotum in size. You can do a Z-plasty on the ventral side, or really I should say you probably do the Z-plasty on the dorsal side, it should really say and a Z-plasty is just doing a Z and then stretching it out and sewing it up, which will give you a little bit more length and relieve tension. But it results in scrotal hair on the shaft of the penis that requires depilation, and it may require degloving and a skin graft if it's serious enough. And of course, skin grafts most of them don't have feeling. They can itch, but they aren't going to have any real feeling. It's a real problem with skin graft. How do you prevent it? Well, first is what's called the Horton maneuver, which is not the standard of care, but I think should be. You inject saline or another chemical to induce an erection before you decide where to cut. You have to pull out on the flaccid penis with the foreskin retracted, which will approximate a full erection. You've got to push down on the penoscrotal junction on the base of the penis before making your exterior incision. You have to use careful judgment, and you should mark your incision lines and then use a hemostat to bring them together to judge the result before you mark or decide where to cut. And I thought, I'll show that again in a minute. I think you have these out of order. You have to consider that foreskins differ. Okay, here's a foreskin where he has pretty tight connections between Dartos fascia and the underlying tissue. You can see here, there's an example of flaccid versus erect. And you can see here with somebody who has a much longer foreskin here, but erect needs virtually everything. He could lose a little bit of tissue here and not pull the scrotum onto the shaft, but you have to be very careful because otherwise you're going to have a disaster. And once again, marking is a precaution, and when I say when you mark it, you can mark on the inside, you can mark, this doesn't show a mark, so it's cutting, but it should be show marking. Mark on the outside, okay? Make sure you then bring the two together, and then you can determine what's the right result before you cut. Unfortunately, the textbooks don't necessarily cover this. Campbell's Walsh Urology says the 10th edition said, one of the most distressing problems we see, however, is a patient who complains that the surgeon has removed too much skin. To avoid this unfortunate occurrence, a circumcision should be done precisely, and whatever the procedure to be carried out, the incisions should first be marked with the skin lying undistorted on the shaft. Okay? Well, what happens if that's undistorted on the shaft? It's a disaster waiting to happen. All right, what about this one? Undistorted on the shaft. If you take all of that off, you're probably going to pull everything forward. So the way to prevent this is, one, you can make your interior cut first, and then after you've made that, which is almost uniformly, once you pull the foreskin back about a centimeter proximal toward the body, or away from the glans penis toward the body. And then you can decide how much you can take off, and the easy way to do that is to pull everything out and then judge what you can do. Another thing you can do is, before you decide anything like this, is you pull out with the foreskin covering the head and see what you're going to be able to do, okay? And stretched length approximates erect length. The Horde maneuver is better because then you really know what the erect length is, but stretch length will approximate erect length and give you a pretty good result. Now, why are errors so common? Well, texts do not correctly depict the penis. They don't discuss the penile skin system in detail. Most doctors today have no personal experience with the intact penis here in this country because they haven't had a foreskin since about day 2. And many doctors treat circumcision as though it were a haircut. Okay? Here's an example, Campbell's Urology 10th edition. I was shocked to see that the Dartos fascia, which they correctly show, starts here and goes underneath. It's the green line. Oh, look at that. It ends before the foreskin. Okay, remember, it's just skin, right? It's just a flap of skin. Well, no, it's not. It's a 5-layer structure. Campbell's Urology ought to know better, but it doesn't. Okay, and that is the text everybody uses. Okay, every med student has that one. Then Grant's Atlas of Anatomy, same problem here. If you get up close, you'll see they really talk about underlying tissues, but they really don't talk about the Dartos fascia. And here you can see that it sort of shows it, and once again, it doesn't show it in the foreskin. So doctors basically have no idea what they're doing. Okay, and I would say, I've been told by urologists, you know more than urologists. Well, only about this tiny little area. But unfortunately, there's a lot of truth to that because they really don't know this. Even the best, the way I got somebody in a case who said, oh, well, that's just in a slide where the glands have been severed. He said, well, that's just the foreskin crumpled up. That's not the urethra. I said, is that right, sir? Would you please name the 5 layers of tissue in the foreskin? And he started to invent stuff. I said, oh, no, I put up Chris Gold's picture. Oh, well, there are lots more areas, okay? And this is a guy involved in, Tony Atala. He's involved in tissue regeneration research. Right now, I think he's still at Wake Forest. Absolutely amazing. All right, so let's talk about infant shaft denudation. This is from a book called Surgical Technique of Circumcision. And look where they've marked out there. I'm going to tell you that I believe that that child is going to have too much skin taken off. Okay, and you can see it right there, all right? That's the neutral position, and the doctors think they're doing a great job and wrote a whole book about it, okay? And I think one of my experts agrees that every kid in that book has had too much skin taken off, okay? So this is the Gomco method, for those of you who aren't familiar with circumcision. It's this medieval-looking instrument. The first thing you have to do is free the foreskin from the glands. You then do a dorsal slit, push the skin back, and apply this bell. Bring the tissue back over the bell. You may or may not connect it like that. Bring everything up through the base plate of this clamp. Connect this bell, his little arms, into this yoke. And then when you push this, when you tighten this nut, because there's a rocker arm here, this closes, this pulls up, and it crushes the foreskin, and then you can cut it off. Well, there's an example of a Gomco clamp where I believe too much was taken off. Okay, and there you can see you can adjust before you've closed this clamp, you can look underneath there and see, are you leaving enough shaft skin? I don't believe that they are in this case, okay, at all. And you can end up denuding the whole shaft. That's an actual picture. I have permission from the parents to use it, okay? This boy was real lucky because this much was left, and an incredibly skillful pediatric urologist used this skin to cover everything, and the child's result actually looked pretty good, okay? But that's an actual, I don't know, kid's probably 10 now, okay? That's, yeah, I see the horrified looks. I think everybody ought to see that, and every parent ought to know that this is a very, very real risk, and I deal with these cases on a regular basis. I wouldn't say every day, but these happen, I think they happen every day in American hospitals. What'll also happen is if the crush line has got everything together and then the kid gets an erection or there's movement, it pops apart and then they start to bleed, and this is where we talked about babies bleeding out. That's exactly how it happens. I've had at least 2 clients with extraordinarily close calls. They recognized it in time, got to the ER. I'm working a case right now where the doctor then brought the ventral side up and closed it, and then, of course, because the records don't get sent to the pediatric urologist thinks, well, maybe the kid was born this way, right? So I'm sure I'm going to hear that. Oh, he's born that way. I can just wait. The deposition's in a couple of weeks. But he wasn't, okay? So, once again, there's the result. You're bringing everything forward, sewing him up with a disaster. And what's the correction? It's the same as a result. You may require a skin graft after release. I've had those happen where the doctor really doesn't know what he's getting into. The kid has a bent penis, so he puts him on the operating table, runs a knife through the circumcision scar, degloves everything, says, oh my God, there's no skin here, and has to do a skin graft. Next, the most common, and really the next most common disaster, I think, luckily it's not as common as the other, is glandular ablation, which is most common with what's called the Mogan clamp. Mogan clamp is this evil-looking little piece here. This is from Mogan Circumcision Instruments' own brochure that assures everyone that the glans is protected and can't be damaged. Okay, I got a $10.7 million judgment against Mogan Circumcision Instruments because of that, okay, where indeed they were wrong and they knew it. And they went out of business and we never collected a penny. So you have great victories and never get a cent. I have a plaque on my wall congratulating me that somebody sent me, and that's all I ever got. But this is what, this was sort of designed after the traditional Jewish shield that was used, which was also dangerous, but I won't go into that. Basically, there's this flat outside. This aperture can't be more than, I think it's 2.5 millimeters. And this is the underside, which supposedly, once you free the glands, grasp the foreskin here with a hemostat, pull out, slip this on, cut out, and then close it, crushes the foreskin, you slice that off, and then you pop everything back, and you have what is believed to be a nice result. But you've got to be careful to separate the foreskin from the glands because of these natural adhesions that are there, and this is how you do it. If you don't do it properly, you're going to have a disaster. Or perhaps when you go in for your dorsal slit, you catch the meatus and you don't realize it. This happened to one of my clients, and put it on, and all at once there is no glans penis. Okay, how did that happen? They didn't even know. I figured it out. And that was somebody who was trained at the Pollock Clinic in British Columbia, who runs a 3-day clinic claiming to train people expertly, and then you're certified. And if I could have sued Neil Pollock and his clinic, I would have done so, but it's hard to go from the U.S. to Canada and file a lawsuit, okay? And what happens? Well, this is actually from the medical literature. You can see all sorts of damage here. There's the glans penis contained within the foreskin. You can see this is a diagram of how it happens. That's correct, that's incorrect. You get a slice there. The little diagrams I've made up, the correct position of the Mogan clamp is like this, where the glans is in that groove and isn't coming through. The way to prevent this disaster is several-fold. You've got to free everything right, and then you can actually, before you close the clamp, pinch underneath to make sure that everything is free. And then you also, before you close, you can just run your thumb across to make sure that it pushes everything back. And then you close the clamp. But as you can see, that you can actually cut off part, particularly if you haven't got this on a slant, you put it a vertical like that, you can take off part of the glans penis. And this is a drawing of what it actually sort of looks like. This is one case with the foreskin removed. You can see some of that. I'm not sure whether, I think that's part of the glands right there. This is another one that was sewn back on, and this was before the repair, and then they sewed this, and the result was, I'll show you these because these were actually shown in court, was like this. And the kid, you know, it was a good surgeon, but he's still going to have a scar. The jury thought that case was worth $30,000, very disappointing. Luckily, I had what's called a high-low, but you never know what's going to happen. You say, oh my God, the jury's going to give you a lot. Not necessarily. How do you prevent this? The aperture is not supposed to exceed 2.5 millimeters. If it's worn and it's larger, they run a risk. You've got to free all the adhesions. The foreskin has to be in the apex of the clamp. You can't pull too hard on the foreskin. You don't pull on the foreskin once the clamp is positioned. The clamp's angle should follow the glands. You palpate underneath to feel that the glands is free. You can also transilluminate, take any light, and make sure you can see the outline of the glands. You can palpate across the top before closing the clamp, and you can assure that the hemostat is not in the urethra. And you can also do a dorsal slit beforehand because that really allows you to visualize everything before closing the clamp, but that is not typical. Other glandular injuries that you can have with the Plastabel, this is a Plastabel right here, these little things, and what's done there is you free up the adhesions, you make a dorsal slit, pull everything back, put this little bell over, bring everything forward, and then tie, and this is, I'm surprised somebody hasn't actually slipped and just tied, you know, tied through the gland's penis, but you have to be very careful to tie in the groove, and then you cut off the excess foreskin and break this off, and the rest is, this will fall off about 7 to 10 days later. But you've got to select the right size bell. If you pull too hard on the foreskin, you can create pressure on the glands. If you don't remove the bell when the glands pushes through in whole or in part, which can happen if you haven't done the right selection, you can have a terrible result. Or you can also have carelessness in trimming the foreskin, resulting in glandular ablation, which happened to, we weren't sure how it happened, but somehow it happened to one of our clients. This is the normal position of the Plastabel, but this is what happens if the ring slips all the way down. And if you've got too large a Plastabel selected or pull too hard on the foreskin, you can get it so the glands rest against the Plastabel opening. So this is the position where it should be, and instead if you've got it here, you've got a problem because you're going to end up with gouging in the glands. So this is from the internet. I think it may be from one of Tim's, it's one from Tim's pictures somebody sent in, and I've had 1 or 2 clients like this, but this is what they end up looking like. That's just permanent scar from Plastabel. And then you can sever the glands, as I said. Severed glands can be reattached. This is an example of where there's the glands and there's the foreskin, and they can actually reattach it. It can work well. Anyway, the other things that you see are tearing open the meatus when freeing adhesions. When you go in to open it up, you've got to be careful. Don't go past 6 o'clock. You should probably just go to 5 and 7 on either side, because if you tear, you can tear the frenulum, which has an artery in it, and there's a bleeding mess. You can also tear the meatus open. And then, of course, you can have uneven skin removal by misplacement of the clamp. In short, ignorance is not bliss. Knowledge of anatomy and function is crucial. Few circumcisers, physicians or non-physicians, know how the penile skin system works, at least in my experience. Many circumcisers are careless. Devastating injuries are much more common than is generally believed. And basically, if there's pubic hair on the shaft upon erection, then more likely than not, the circumcision was botched. By report, this is very common. Frankly, I think up to 1/3 of men in this country, this is just my rough guess, have had too much skin removed. I think that's a fair estimate. Final thoughts here, that even in the books, maternal and child health nursing, they'll talk about, well, this is optional, but then they list a parade of things that supposedly circumcision prevents. I think we all know this, and never deal with the functions of the foreskin. Okay, you know, here they talk about at the distal end of the organ is a bulging, sensitive ridge of tissue called the glands. Well, no kidding. A retractable casing of skin, the prepuce, protects the nerve-sensitive glands at birth. Based on religious or cultural beliefs, many male infants have the prepuce tissue removed surgically, parent circumcision unparent shortly after birth. Although controversial to some, the American Academy of Pediatrics recommends male circumcision be done in consultation with parents for all male infants because the practice's advantages outweigh its risks. Its advantages allow better hygiene and then the whole parade of horribles. So, I mean, parents, nurses, nobody's being properly informed. Campbell's Walsh Urology, once again, talks about preputial retraction increases with age, with 90% of uncircumcised boys 3 years of age with completely retractable prepuces. Okay, that is not true. I mean, even Gardner, in his 1949 article, was saying that 90% by 5. Again, in his sample it was. We know from the Kayaba article, which is accessible at cirp.org/library/normal. Okay, you go there, you can get the Kayaba article. That's the one that makes it. It's from the Journal of Urology, an American journal. Okay, 1996, and it shows that it takes to about age 10 and a half for half the boys to be fully retractable, which fit in with the experience of my sons. One was fully retractable about 8 and a half, and the other at 10 and a half still was not, and they're both retractable today and have intact kids. Okay? So here's the other thing. I think, John, somebody already alluded to this today, but this outrageous thing from the AAP technical statement from the 2012 thing saying the most adhesions present at birth spontaneously resolved by age 2 to 4 months. Okay, that's just a lie. I mean, there is nothing in the literature that supports that, nor this footnote 25. Oops, sorry. This footnote 25 here, I invite you to just go look at it and then read the article, and it says nothing about it. I don't know where they got it. Somebody just invented it, okay? I'm going to have fun if I ever get a case where I can use this against them. That's it. I just thought you all would like to know that. Hopefully you never know anybody with a botched circumcision, but if you do, there's my contact information. Business cards are available at the desk out there, and I'm here to talk to anybody at any time about it.